Hello, this is Lori Colley, Senior Manager of Clinical Redesign from Pacific Business Group on Health. Before we start on day 2 of our Sustainability and CQC Academy, I wanted to turn the clock back in time and just give you a foundation of Pacific Business Group on Health and how we got to the Intensive Outpatient Care Program. So Pacific Business Group on Health, we're located in San Francisco. We're a nonprofit founded in 1989, and our key strategies focus around the elements of engaging consumers, paying for value, redesigning care delivery, and advancing value-based policy. Pacific Business Group on Health addresses these key strategies through contracts as well as federal and state grants. So when we are funded, we provide implementation and training to healthcare organizations with these key strategies as a primary focus. The origin of Intensive Outpatient Care Program is in July of 2012, Pacific Business Group on Health received a Healthcare Innovation Award from the Centers of Medicare and Medicaid Services, and that was to implement and spread an intensive outpatient care program throughout 25 medical groups in 5 Western states. As of the end of June of 2015, or by July 1st of 2015, we hope to have 15,000 patients who have been touched by care coordination. Also, we have promised the Centers for Medicare and Medicaid our 3-year targets of a 5% reduction in the hospital and emergency room visits, a 2% improvement in clinical outcomes such as LDL, A1Cs, and those type of clinical improvements. Also, a 2 to 4% improvement in patient experience, and an overall total cost of $29.6 million in savings. So let's talk a little bit about what is the Intensive Outpatient Care Program. It is a focus on high-risk patients with complex medical and behavioral health needs by providing a high-touch, patient-centered intervention. The overall goal of the IOCP is to keep patients at home in their communities. And the program emphasizes the use of care teams of registered nurses, social workers, health coaches, and health navigators, while also that are embedded in the primary care physician practices, and really addresses the medical, behavioral, and psychosocial needs for patients with chronic illness and comorbid conditions. The care coordinators work closely with the patients to coach self-management and support behavior change. The organizations that participated in the IOCP grant are listed here. We've had 25 medical groups. Some were IPAs. Some were a total healthcare system of hospitals and medical groups and IPAs. So we had quite a variety of different healthcare organizations. Also, we had quite a variety of what these organizations had in place even prior to IOCP. Some were a heavy lift, some were a light lift, and that is that they may have not had any type of care management model in place, or they were quite sophisticated and had population health, care coordination, care management in place, and they simply laid our IOCP program on top of that and participated in all of our trainings. Pacific Business Group on Health, along with Renaissance Health, provided leadership training. We provided care coordination training, and we kept those trainings ongoing throughout the 3-year project by facilitating collaboration amongst all of our medical groups through webinar meetings as well as face-to-face meetings. And we also focused on care coordination skill sets by providing office hour training on a bi-monthly basis, as well as case conferences where the medical groups and the care coordinators shared some of their case studies with our clinical advisory board members over at Stanford Coordinated Care, Dr. Ellen Glasseroff and Dr. Ann Lindsay. So a little bit about the care model. The care model serves as a link to the primary, specialty, and ancillary services. Just kind of think of the care coordinator as the quarterback. He or she is the person up in the control tower with a 360-degree view on the patient, their families, their community at all times, and guiding that patient through the different doors of the healthcare system, developing a trust and lasting relationship with that patient, and developing a shared action plan with that patient on goal centered of what the patient really wants to work on and what is meaningful to the patient. Really kind of a personomics type of philosophy with really getting to know that patient, getting to know what makes them tick, so that the patient and the care coordinator and the team really drive the coaching based on that patient's wishes and that patient's activation level, so that they're engaged and able to be successful in their goals, whether they be baby steps or the baby steps lead to bigger steps. The care coordinator also provides referrals to the behavioral, psychosocial, and community services, and the care coordinator participates and leads team huddles so that he or she can tier their caseloads and better manage and monitor. And also we saw that the team huddles really provided a way to ensure workforce engagement and support in this highly, care coordination model. I'm going to stop now with our review of the Intensive Outpatient Care Program, and we're going to begin our day. Thank you.
So first of all, I want to thank you all in this room for making IOCP so successful. We have 14,200 and something patients enrolled, and that's thanks to all of you, and you've made us very successful. And the reason that we did not get the no-cost extension that we had asked for and proposed to CMS is because this is such, in their eyes, this is such a successful program. These are their words, and we will sustain no matter what. It's thanks to you that we are that successful. But actually, there is another step to it. So CMS did give us a year-long extension that has to do with working with the state of California, Department of Healthcare Services, and the Health and Human Services Agency to provide training and technical assistance to the safety net, those who are going to be starting what's called the Section 2703 health homes. And Section 2703 is from the Affordable Care Act. So we're going to be doing the same thing and spreading this model, but toward a different population. And CMS has been very emphatic that none of these funds that are going to keep us going for a year can be used to support the program we've been doing for the past 3 years. So that's where we're going, and that's why this is our final meeting. This is a lot. The morning is really about what did we learn? How do we integrate IOCP care model into your clinical approaches and your population health management programs? We're going to do that in various ways. We're going to have some panel discussions as well as table discussions. And Emily and Sutep are going to talk a little bit about the survey we sent out so that we could here in the office could get grounded into how many of these programs are going to be sustaining in some form after the grant. And it turns out most of you will be sustaining the program. And we're going to use that to springboard into, again, how you integrate this, how you're going to take IOCP and take it to the next level. Rob is going to talk about data, some new measures that we haven't seen before, as well as the measures that we're commonly sharing at all of these meetings. And Diane Stewart's going to talk about PBGH's strategy, taking this model into other payers and to our employer members. But I want to say big thank you to Sutep Lahavanich and Tim Chafin for what they've done putting this together. One thing that came up over the reception last night after the meeting is talking to a few groups, and people stated how much they're going to miss this learning collaborative we have and all of the relationships we've developed over the past few years. And that led to another discussion about how we can keep this going in some way, maybe through webinars. A couple of the groups have said that they would help support that. It would be nominal, I'm sure, because you're not paying for meeting space. But we're going to take that back to the office and cogitate on it a little bit and see if we can make something happen so that you all continue to have access to one another. So I'm going to ask for a show of hands. Is that something you would be interested in us exploring? Wow, great. Really nice to see that. So we're going to look forward to continuing to partner with you. And then SUTEP specifically is going to set this meeting up so that there's going to be a mixing of groups. So we're going to ask you to fan out at various points so that we have multiple groups at the same table. And then we'll have some facilitated discussion, and then this will be incorporated into our final report for CMS, and it will also bring it back to the office so that we can take our best practices and learnings and use that to continue as we work across payers and now continue this collaborative. So I think there's only one more thing I want to say that has to do with the internal folks who have been supporting this effort. So I want to acknowledge our clinical advisors for all of the guidance and support they've provided to us and all the experiences that they've shared with us. And then finally, I have some acknowledgments for staff. So everybody has commented to me on how much they love working with this team and how hardworking they are, and I will also add to that dedicated, smart, fun, and but above all, they've been instrumental in helping us be successful. So I'm going to tell you a little bit that you might not know, and as I call your name, please stand up. So Rob Benroth brings to us, we're going alpha, so everybody can get prepared. Okay, so I want to acknowledge Rob for his ability to translate the language of data and research and MedInsight and flat files into a language we can all understand. And Tim Chafin, Tim, stand up. Good. So Tim, everybody has met him, and you've probably noticed that he has these wonderful Southern manners and a kind of gentility that has elevated us all in the office by the example he sets. So, and Lori Colley, for her, for her ability to find a silver lining under any circumstance. And Amit, stand up. So Amit has gone on to some really great things. But when he was here, he was so committed that he once, when he couldn't fly on an airplane, drove up to Seattle for a meeting with Polyclinic. And SUTEP. SUTEP is unflappable no matter what's going on. And he steers the ship and kind of keeps us all calm. And Emily. So Emily has really great networking skills, and through that she has connected a lot of us, and she has also helped spread the word about IOCP to others who were not in the room. And I'll also add that she has great negotiating skills, and she has saved IOCP a lot of money. And Diane Stewart. Diane has frequent peals of laughter that roll through the office and bring levity, and I should say levitate us, at all times. So I want to thank everybody. And with that, I'm going to turn this over to Sutep, Emily, and one of our clinical advisors. Is that you, Lisa? Okay, great.
For this part of the day, we wanted to share with you the feedback we received about a little over a month ago. We asked all the groups, we sent out a little survey on how you will continue IOCP in parts, or what guardrails you'll be keeping and what transition plans our group's doing. So we wanted to share sort of a program-wide look of where all the groups are going, and I think you'll see through the data that we provide here, it's very encouraging that the program will be continuing in various forms within your organizations, and I think you'll notice, where you're expanding the model further, and it's very, I think it's just very positive outcomes, and demonstrates all the work that you've done. And then, so we'll cue it up to Emily to talk through some of the slides.
Okay, so thank you very much for the 20 groups that did send in their responses to this survey. They were very eye-opening and, like Sutep said, encouraging. As most of you can probably relate, the physician engagement was definitely the hardest part of implementing an IOCP. You said it was hard to find a physician champion that was dedicated. A lot of the physicians thought that the program would be extra work for them. It was hard for them to give up control of some of their patients and their clinical activities. It was hard to engage the clinical staff, the office manager and the medical assistants at the office. And a lot of staff at the medical offices had trouble distinguishing IOCP from other care management programs. They just said there are too many programs, we don't understand why there's another one. What is this one going to do for us that the other ones haven't? And for staff, you said it was a longer ramp-up time than you were expecting to get staff onboarded. Recruiting staff could be challenging, especially from groups in certain geographic areas. And it's hard to find the right person. Like many of you said yesterday, you can hire someone with the right experience, but if they don't have the right personality, it's not going to work. For patient identification, it was finding the right patients that were appropriate for the program, and also tracking admissions to the hospitals. You didn't have insight into the data systems there. For patient engagement, you had to fight with ambivalence on the patient side, PCP buy-in in terms of getting their patients to enroll in the program, and it was hard to build a trusting relationship with some of the patients. It took a little more time than you thought. For assessments, you found it hard to track when the repeat assessments were due and to get those into the system. Guardrails, mainly tracking them, having a dedicated project manager to hold people accountable to the guardrails, and the face-to-face was also very challenging. For other activities, data was outdated, as we all know very well, hard to prove ROI, hard to get data entered into the system, and working with different EMRs across different systems. Okay, so maintaining guardrails, we were very thrilled to see that most of you will be maintaining the face-to-face, which we think is a key tenet of the program. Shared action plan, 100%, not a surprise there. Some of you may continue PAM. We understand that there is an extra cost to that. VR12, it is free, so I'm not exactly sure. Maybe we can discuss why only half of the groups will continue that, and the PHQ you all found very useful. So what will be changing, most of you will change your patient selection criteria. And it was interesting that across the board, most groups said they're going to include moderate risk patients, not just high risk patients, that rising risk we were talking about yesterday. And a lot of groups will be opening up to all payers, which I think will help with your physician buy-in a lot. And in terms of graduation, 6 months is looking like a good time frame instead of a year to have the patients in the program, and a lot of groups will focus on specific diseases and modify their programs from there. Let's see, for assessments, Dr. Glassarf will be very thrilled to hear that the ACE assessment will be used more frequently. that focuses on trauma-informed care, excuse me, and also social determinants, like loneliness, ability to pay for medications, transportation, that sort of thing, and I'm very happy to hear that. Contact, it will be less frequent than monthly, and also disease-specific. And for office visits, some groups will be using telephonic more frequently than face-to-face, and also more variety in the locations where you can see the patients, such as Starbucks or movie theaters. People had some interesting ideas of how to track the patients down. And for staffing, we were very heartened to hear that social workers are now a key part of the team and will continue to be part of the teams in the future, as well as community health workers and other staff depending on the ROI that can be demonstrated. Transition planning. You can see the obvious points here. Some interesting things in the other category that came up where some will be developing alternative reimbursement models. I'm not sure exactly what that means. And also strengthening linkages to community resources like Meals on Wheels. Is that it? Okay, wait, one more thing. So last but not least, a lot of you mentioned the value that IOCP has provided to your groups. There were 4 things that came up as major themes. Benefits to patients, the structure that it provided to your organization, collaboration, and the support from PBGH and RenHealth. So for patients, obviously improving health, minimizing emergency department visits and hospitalizations, which is the core tenets, why we're all here in the room. For structure, you thought it was good to get your teams formed in place so that you could continue this with your other care management programs down the road. You liked having a structure to implement the assessments in terms of getting them into your EMR and just having it as part of your standard workflow. For collaboration, it was learning best practices and networking with your colleagues and your peers. And last but not least, PBGH and RenHealth support. You appreciated the training, so thank you very much to Pranav and Jonas and all of our clinical advisors. Guidance and support and the process improvement.
So while we queue up the presentation, this session is going to be co-facilitated by Pranav and I, and we'll see how this works. So IOCP's long and winding road. I wanted to take a moment just to recap some parts of the journey as they touched upon our data lives and data collection lives. Going back to December of 2012, that was the first time that we had groups that actually submitted claims data to Milliman, so 2.5 years ago now. It took about 6 months. May of 2013 was the first time that a group had access where their claims had been processed and were available for use in the MedInsight product. If you do the quick math there, that was about 6 months, and that was much longer than any of us anticipated that taking to process claims. Some of you in the room are still waiting for your data claims to be processed to have access to MedInsight. Kind of continuing down the road, it was spring of 2013, or summer of 2013, where we first had access to the EA tool. So many of us struggled as we were requiring these different assessments. How would you collect and score this information? So we developed the EA tool, but that didn't become available to you until 2013. And then finally, it was actually early 2014 that PBGH for the first time had the ability to consolidate data and begin to report out on multiple groups together through MedInsight. So, and that was just over a year ago that we've had this ability. So what I wanted to do in this presentation was actually look back at some things and then contrast where we are now, and that's what we're going to spend some time in the first part of this presentation. So what we're showing here is IOCP enrollment then. So this was the first time that we reported data to CMS in one of our quarterly reports. This was the end of the first year of our grant, so I just want to note how far we've come in the 2.5 years. At the time, this was June 30th, 2013. We had 413 patients enrolled. So we were far from our goal of 27,000 enrollees at this time. And at that point, we had only 4 groups that were participating, that their programs were up and actively enrolling patients.
I will say Rob was always the optimist on this, because he'd somehow show us graphs that showed trajectory that always got us to where we were trying to go. He'd be like, but if you played this out really, really well, it would always work out. And he was right, I guess.
Forecast. So just to contrast this, here's where we are now. So we now have, and the graph here is showing 13,000, but we're currently over 14,000 patients that have been enrolled in IOCP. We have 25 organizations across 5 states that have been enrolling patients and contributing to this number. And you can see, as we were talking about, the slope has really shot upward as new people contributed, as programs got up to speed, and we got more and more groups enrolling. And it's quite a contrast from where we were just 2 years ago, looking at our enrollment totals. So that's a testament to the work that you've been doing.
Do you mind if I ask a question on this to the group? One of the things that probably led to the rise in enrollment is just more groups were participating. As Rob said, there were 4 in that first graph, and we have over 20 doing this now. Do you guys, what are other triggers that you observe that really switched that ramp, like from whatever pace you're on to significantly higher pace? Yeah, try and be interested in where those trigger moments were, what those specific actions were.
Interestingly, our single group graph looked a little bit like that as well. We took a slighter slope in the beginning, and then it ramped up a little bit. I think that was just due to building out the program, getting used to what the guardrails were, adding more staff, understanding who could do what. At first, we started off in 3 different buildings. Now we're in the same building, so that helps. But just the process of building the program, I think, helped give us kind of more of an exponential graph rather than a straight line graph.
Mm-hmm. So it was a few things to pull out of that. It was adding more staff makes sense, kind of capacity-wise. Was in the building out, was it like physicians started knowing, or was it the co-location, or some of the thoughts on the most critical pieces?
Well, I think co-location is nice. Physicians becoming more aware of what we're doing. The nurses just becoming more efficient at what they're doing. I think it's just a learning process for everybody, as an organization, as a team, as a nurse. Everything. Just the longer you do something, the better you get at it. So I think that's just why we saw that.
Others? Other thoughts on kind of how your graph had that upward swing? Yeah, Crystal.
For ours, because I know we just recently.
Thanks, Dan.
Oh, thank you. For ours, because I know we just recently had a call, and we had ours are like hills and valleys and flatline for some point in time. But our difficulty with staff at some point in time, because when you only have one case manager, you can't always enroll because someone actually has to take care of the patient. So you can't have an outreacher and someone taking care of the patient at the same time. So that's where our challenge was at, okay, at some point in time, we have to stop outreaching and focus on the patients that we already have currently enrolled. And, because that time restraint and trying to meet with our case manager's assessment deadline within, 30 days, getting certain things done, then go back outreach, and then again stop again, outreach, stop again, outreach, stop again.
Hence the hills and valleys.
Exactly.
Yeah.
So that's where our difficulty was, because we were stuck with the staff that we had, which me.
Longer conversation another time, it sounds. Other thoughts?
Well, that's actually a great observation. Just as we share with you your individual enrollment charts, it's a very common pattern that a group will start off very fast out of the gate with enrollment and reach a point where they're enrolling new patients and reach a plateau where the staff are at capacity and really don't have the ability and need to discover where that balance is between enrolling new patients and maintaining the patients that you already have in your panel.
Vilma, did you have a comment?
Yes, our trajectory looks actually even worse than how that looks, because we were really slow at the beginning, and then we hit a point about a year or so ago when we finally got it. We finished all the quality improvement, rapid changes that we were doing, and hit the right processes in place and the workflows kind of melded better. We reorganized our team, and then we started enrolling, and we were able to sustain that all the way, hopefully till June 30.
So you had a process that was sort of slow incline. You
Yes.
refined a bunch of processes,
Yes.
and you saw the increase. Do you see that happening again? Like, let's say we kept going. Do you think that now you're on that ramp, or would you see a flattening or even a higher
I think
incline?
now they've gotten the process so well entrenched in the way they do things that it is so easy. It used to be like we were monitoring from week to week, and they'd go, well, this week will be good, next week may not be. So that kind of talk has gone away. It's now really hardwired into the process that they go, well, why are we stopping in June 30? We should just continue. But we are still in the process of putting together the IOCP 2 plan, so we have to have a little bit of a downtime to wrap up our data, and then we'll start the IOCP continuation program.
Great, thanks. Oh,
Program, of course, everyone's going to want to be part of it. But then the piece of making sure you hire the right care manager, and that's what would slow the progress, because the demand was there, but the supply was limited. And so we were really methodical in who we thought would be the best care manager. We had a lot of nurses to choose from, but the ambulatory care manager who understand this program and who could fill the needs, I think that was a challenge in keeping the enrollment trend going up.
so sort of a supply-demand matching. And do you still feel that way, that you have a lot more demand than supply?
Yeah, yes, so we need to continue to roll that out to all of, I mean, of course, the IPA physicians aren't as engaged as our foundation, but we do have so many more physicians. We have maybe 600 physicians in our system that we need to continue to enroll, but the supply is not there, of course.
So maybe same question to you that I asked Vilma. Would you see then your curve actually inclining even further? Or how do you?
If they allow us to hire more nurses.
Yeah, so that's the constraint. That's interesting. Great, thanks.
Okay, so let's, this is great. So I wanted to show that we began having leadership calls where we began collecting and sharing data back with you in order to give you some feedback on performance with enrollment and guardrail adherence. So this was from fall of 2013, and this was the first time that we shared an enrollment graph with you looking at the enrollment by group. So at the time, this was enrollment through the end of November. There were about 2,000 people. A couple things that I want to note here is if you look along the bottom, the first time that we began sharing graphs with you and information, everything was blinded. And so you didn't know, we'd unblind who you were so you could see where you stood, but everything was blinded because we were kind of all new at this, and we needed to develop kind of a circle of trust, if you will, about being open. And I think this was also, at this point, when we're looking at enrollment by group, at that point, Sharpry-Steele was not the enrollment leader. So then what happened after this, and also note this was only Wave 1 group, so as of November of 2013, we just had 10 organizations representing our Wave 1 groups. And more recently, this is the graph that you've seen now showing a number of things. First of all, there's all 25 organizations. Through these collaboratives, we've built trust and relationships and understanding that all of the information is unblinded and open, so we all know who everyone is and how you're enrolling. At some point, Sharpry-Steele took an enrollment lead and has never looked back. And you can see on the far end, we'd always grouped you according to the amount of time in which your program had been launched and operating. And now more recently, we have several programs that have been operating and enrolling IOCP patients for more than 18 months, and for some of you, it's more than 2 years now.
Yeah, no, that's just pretty impressive to see, kind of one graph to the next, and then also sort of the amount of, I think, ramp-up period that it does take. So even if you're looking back at the 8 to 10 months launch, the volumes are low, probably for multiple reasons, but even just hearing the few comments we had, it sounds like if you're starting from a base where you don't have sort of care management built in, there's a lot of things you have to develop in order to get PACE going. Is that what I'm hearing for the groups that maybe didn't have care management initially? That ramp up, that build up? I'm seeing some nods. Any comments on that from groups that sort of had limited care management experience prior to IOCP?
Because when you see somebody that has success in one area or all areas, it's really good to pick their brains. And what they taught us was it wasn't like one person's job. Like we had hired an IOCP nurse, and then, right? And we had a social worker. And it was everybody's job. So when we learned of that, we rolled it out to every staff member, including complex case managers who don't report to me that are in another department, because we realized that if you can give a consistent message and that everybody gets engaged in this philosophy, and that's when our numbers took off, because you couldn't do it without that. It's very difficult to do with one or two nurses working on the program. And I think that's the goal anyway, right? For all of our practices and our physicians and our groups to be able to function like this. So I have to give them kudos because they really spurred us on. And I see they're still here, right? Are they here? Because I know some of the leadership changed. Yeah, some of the leadership changed, but they really spurred us on in the beginning.
Yeah, that's neat to hear how the data transparency led to the ability to have that conversation, because then you knew who else to talk to. And I hopefully that continues as you see any of this data, that you guys have opportunities to collaborate with each other based on learnings from other organizations. Maybe a question, and not to put anybody on the spot, so if it goes silent here, we'll move quickly. But for some of the groups that are still sort of early in your process, do you feel like you're going to have trigger moments, or do you feel like you have challenges that are significant barriers? Would love to kind of hear those challenges, if anyone's willing to share.
So we want to go back, and this is keeping in consistent with sharing data with you and providing feedback. So we began looking at IOCP program guardrails. So we laid out some of these different things, and we selected a few that we had the ability to capture data and provide feedback to you from the EA tool. And this was the first time that we shared data with you about guardrail adherence. And a couple things that I want to highlight here. First, again, notice that everybody's blinded according to your performance, and we just had the Wave 1 groups. And we looked at two of the guardrails. It was the completion of the PAM for enrolled patients, and we used this basically as a proxy for all of the assessments. And then looking at the documentation of a shared action plan being initiated in the EA tool. And we talked about the program guardrails, and in the spirit of rapid cycle data collection and providing feedback for quality improvement, the first time that we reported this, we were quite surprised as our program, and I've highlighted there, the first time we reported this and shared it with you, our program average for PAM completion was just 62%, and for the shared action plan was just 49%. And we got engaged in different discussions and finding out whether or not those numbers, first of all, whether or not they were real, whether they were issues of guardrails not being met, or whether it was something about a data collection issue, and worked through, and all of the groups had different stories to tell. But through the process of sharing this information, we've made some remarkable changes and improvements. So it's a little bit convoluted, but what I want to draw your attention to, if you can see it in the back, the PAM completion went from 62% program-wide to just under 90% program-wide, and the shared action plan completion went from 49% to over 90% program-wide. So that change occurred really in about a year and a half's time by making you aware of the data that we were collecting, letting you know how we were collecting it, and bringing your attention to the different things. And then notice once again, it's become a crowded slide, but yeah, it's unblinded. Now we have 25 different organizations that we're reporting on here.
Yeah, that one was one that was really neat for us to see, as Rob said. So it was shared, I think, in late 2013 at one of the clinical advisor meetings, and we looked at it and said, oh, that's sort of surprising. It's a guardrail. Let's try to understand a little bit more about it. And then the PBGH team heard from you guys. Would love to kind of hear what changed in your organizations. What took you from, for example, on the shared action plan, 50% to almost 100% really? What did you do different? What was the process? Was it just the observation that drove it, or was there something else you guys did that's different? Crystal, thanks.
Well, I know for us, it was the coming to the conference, a lot of the on phone, but it was really specifically Lori. Because we was really struggling with getting the questionnaires done, because you're dealing with a lot of senior patients, and the PAM along with the VR12, along with the PHQ-9, to them that's just an overload. So Lori, coached us on incorporating those questions into a general conversation. And so once we start doing that, basically we had to practice doing that first. And once we got accustomed and got used and comfortable with doing that, that made it so easy for us to get those done. And that is what really helped.
Oh, interesting. So some more discussion learnings around it, and then encouraging the care team to do it, and they were able to do that.
Just asking question by question, turning into a discussion. And they never knew that we were asking them those questions.
Right. That's great. Others? What? Yeah, Stephen.
So we started out mailing all patients, right? When they agreed to roll into the program over the phone, we would mail out all these assessments, and we, begged for them to mail them back. Sometimes they mailed them back without their names on them. So we made it our practice to write their names on them before we sent them out to them. But I mean, it was a learning process, and then eventually we made sure they got completed when they came in for our super visit. I think I mentioned that we weren't following the face-to-face component at the beginning as we should have been, and then we got everybody through it that second, the beginning to late summer of 2014. So when they came in, we made sure that we got them all done before they left that super visit. So.
Great. Yeah, and that was a big shift, I remember, for you guys to go from non-face-to-face to face-to-face, which credit to your organization to figure that out. A whole new process, actually, that occurred. Scott.
One thing, too, for us is once the EA tool was up and running, we had to come up with a process because our nurses were doing the assessments in ASET, our documentation system, so we had to figure out a way to get them into the EA tool. So we were using non-clinical staff to transcribe the assessment. So just coming up with the process of getting them from one system into the other took a while to train the staff on how to do. And even the non-clinical people, because there were so many steps to tracking the consent and the assessments, sometimes they just miss one step. So being able to run the reports out of the EA tool, just do the QI monthly to see where you're at. A lot of the assessments were done, but it still takes time for them to get to the EA tool. So even now, at any time, depending on, like last week, we had 2 people on jury duty, 1 out sick, so no assessments got transcribed for a couple of weeks. So at any point in time, there's always a lot of variation, of course, but it was really coming up with the process of getting the assessment done, putting a task in, having the task shared by people, so it kept the whole system moving. But it made a huge difference, and that's where the EA tool really was helpful. You could run those reports, see where you're at, and track them down.
That's interesting and helpful. Any thoughts on that EA tool?
Yeah, actually, I'm glad you brought that up because I was going to say something too. Because when we began sharing data with you, what we discovered was a lot of times the issue was the documentation of the guardrail taking place, and we found out from you that it was occurring, but you needed to get the data in there. And then we realized that we needed to work with Milliman to make enhancements to the EA tool to give you the ability to better track and manage your own information.
It's a neat learning cycle. Kelly.
So we did a little bit of adjustment. We've always had the shared action plan as part of the program. That's what we've done, with our commercial and with the IOCP. But the PAM was a little bit of a pushback. Once you get the initial one, that was not a problem. It was the second one. So in our interventions database that we use for our staff, I added a radio button so they could actually run their own report as to who needed the PAM. So we went from like 50% completion to like 84, whatever instantly because they didn't have to go into 2 different areas to look and make sure their patients were actually when they were due, and so that helped quite a bit and add it into our own database for them to sort their own information.
Yeah, I mean, there's a theme in some of these comments around making it easier in the workflow. You talked about making it a discussion as opposed to sitting down. You talked about some mailings and how we do that and how you brought it into your own system so it isn't 2 different places. It's probably true across any tool you're using. If you find it really important, it has to have an important part in the workflow for it to be really effective. Janet? Diane's doing a great job. I mean, pretty impressive. Diane,
will you put on my Fitbit?
This is a very good discussion because we're all working towards efficiencies because we don't have the staff. So with the purchase of the PAM tool and the use of the VR12, we also have the additional cost of getting it into our documentation system and making the case to senior leadership and budget people that if I spend $30,000 to get everything in my documentation system, I'm not paying an MA or a nurse to do double, information, and then we can get the results back. So it's that discussion that sometimes people don't understand. Oh, we're not going to pay for that. You can't put it in the system. We have a workaround, but the workarounds cost a lot of money. Mm-hmm. And then if you can have it in the documentation system, we get real-time information and we can accurately assess that, yeah, all the scores are in. They're all done. Instead of now, well, it doesn't look like it's 100% because we have 50 waiting to be put in.
Yeah, that's really important. How do you measure, in that case, how did you measure what the workaround was costing you?
Well, I don't have actual costs, but I just went, Scott kind of gave me an idea of how many people were working on implementing or putting in all these assessments, and it's not sustainable.
Yeah.
Because some of our MAs are putting in the assessments and they could be making the calls, and that's what I want everybody doing, making the calls, as
Right.
some of you know from last night. So I don't want them doing manual work, putting assessments in. And I mean, it even got to the situation where they wanted to work earlier hours because they had all this work to do, putting everything in. But if you start work at 6 in the morning because you have this in, you can't call patients at 6 in the morning. So you really have to look at all facets of your operation. And in order for efficiency and to build more patients, outreaching to the patients, because that's the goal. We want to be talking to the patients. It's worth the money to get it into the documentation systems in the long run.
Yeah, I really like that, measuring all facets, whether it's hard measuring or observation. So, because you talked about the cost, hard or soft, on people inputting, but even more compelling might be that opportunity cost of what they could be doing. So if we could get them to stop needing to input data, they could do a whole lot of other things.
Yeah, we ended up having to create a SQL database with a web interface where we were able to track, how often these assessments needed to be done, because we have Epic, right? But it's not a very good workflow EHR from the perspective of being able to track these patients and when you need to do the assessments. So we have that we built last summer by our decision support team to help us.
Yeah, so you guys invested as well, thinking that was the right movement forward. That's an interesting common theme. Grenda.
Because we didn't have a high completion rate, and so it really helped us to discover that we were actually enrolling quite a number of dementia patients. And I know that wasn't a population that we were targeting, but we really didn't have another program to support this population. So it really helped us drill down. We have 11% of patients that have a dementia or cognitive impairment, and that we're supporting in this program. So so that was kind of enlightening for us, this particular based on the data.
And that's a great example of what we sort of ended yesterday with, this notion of if you reflect, you might actually find things that you weren't specifically looking for, that sort of rise up, and you're like, whoa, that's something we weren't planning for, but that explains why, despite our best efforts, we actually have a low completion rate. That's interesting, and it's something Rob and I talked about even as we were thinking about this discussion, how data really, the importance of it is translating it into observations, translating it into then actions, refinements, and it's really neat to hear kind of the things that everyone's doing.
Well, that was a lot of fun, kind of looking back and contrasting that with where we are now. What we want to do is change gears a little bit and present some of the results program-wide for the assessments. And you guys have seen most of this before, but I don't know if we've shared data with you, this information in this format this year. So let's take a peek at kind of where our program is with all the assessments and the hard work that you've been putting in. First, the takeaway with all 3 of the assessments program-wide that we have seen positive changes in the PAM, PHQ, and VR12, and we'll go through these in some detail now. This slide is looking at results in the PAM measure, and we've looked at this in several different ways. So first of all, with the PAM, the instrument, it gives you a quantitative score. And we've seen the quantitative score has increased from 57.8 at baseline to 61.6 at follow-up. And that's nearly an increase of about 7%. In addition to the quantitative score, the PAM also categorizes the scores into different patient activation levels. And the bar graph shows you the distribution of the PAM levels. So for example, what you see is the blue line represents the percentage of level 1, so 24% of the people were level 1 at baseline, and so on. And what this shows you is that the blue line represents baseline, the red line's follow-up, and you see this shift that occurs toward higher levels of activation. So at follow-up, we see fewer people in PAM, the low levels of activation, PAM levels 1 and 2, and this upward shift, and people are moving toward, at follow-up, more people in level 3 and 4. And what we noticed when we looked even a little bit deeper then is that almost 40% of the IOCP patients didn't just have an increase in their activation score, but their score increased enough so that they went to the next higher level. And so we had 37% increased a full activation level. Just under half of them stayed the same, and 18% actually went to a lower activation level. Could be attributed, as we've talked with people about events that are going on that might be traumatic and to explain something like that. But overall, we showed some really positive results and have continued to. Our numbers now are over 5,000 patients that have had repeat PAMs and at least one repeat PAM. So we have quite a bit of stability and confidence in the numbers that we have here. As many of you know, at the beginning of May, Lori Colley and I went up to the Insignia Health Conference, and we presented IOCP findings at the PAM conference. And this is something that we haven't shared with you, but we looked at the relationship between patients graduating from IOCP and increases in how their PAM scores changed. And we found some pretty interesting results. So the table up here shows you along the left if the PAM score increased, was the same, or decreased, and that's our total number of graduates. And what we discovered is that the graduation rate is 30% higher for patients that had an increase in PAM score compared to patients that had a decrease in PAM score. And that's pretty profound. And as we reflected on that, it made a lot of sense because when you think about patients that are higher activated, they're more likely to reach out, meet their shared action plan goals, and make kind of some of the positive changes that they can make in their lives in order to stabilize and graduate from IOCP. So we thought this was pretty interesting, and we were able to validate a common sense finding with some data that we had collected.
Maybe pause just for a second on the graduation part of this slide. How are you determining when to graduate a patient? What are some rule sets you're using, or some observations clinically that you might be using to determine if someone graduates?
Essentially, we used a tier system with the red, yellow, green. Patients that were red needed higher levels of intervention. Patients that were yellow were able to be a little step back on the calls. And once they got to green and they stayed there for a while and they just needed intermediate follow-up, and then less frequent, once they were activated on their own, stable with their clinical measures. And they didn't necessarily become disenrolled, but we would follow them, and I think the minimum was 3 months. And if they stayed green for about 3 months, then we said, okay, you're able to be graduated.
I like that, a formula around that and observation.
I think we've established something very similar. We tier the patients. We use 4 levels, though, green being the lowest. When they get there, we kind of consider we're not really coming up with any active goals for them. They're not coming up with any of their own. They're kind of maintaining very well. They're stable, and we watch them for about 3 months, make sure they're able to maintain that. Some patients a little bit longer. But what we have found is patients that are disengaged, that are not returning our phone calls, not contacting us through our Epic patient portal, we're trying to graduate them, or the patients that we think have kind of met their goals and we've given them all we have to offer, they're saying, wait, no, I don't want to lose you. So we're not really graduating as many as we had hoped, but we do kind of keep them maybe on the back burner and maybe it's that 5-minute touch every month, but not the major intervention. But a lot of patients aren't wanting to go anywhere. They're wanting to stay connected.
It does. In the EA tool, we collect about a dozen different reasons that patients drop off, and this is just looking at patients where you've defined, however you've defined graduation in your organization, that's what we're capturing here.
We'll start here, and then Jan and Phil.
In response to that about the patients that aren't ready to let you go, we've found that as well, but the staff have been wording that, I'm always here for you. You can always call me with any questions or concerns. So we still graduate them, and then we put the ball in their court if they do need anything. And we don't get too many callbacks, but it allows us to take in that many more new patients, high risk, recently hospitalized, that need us more, lower activation levels, et cetera. So we've been working on how we plan to continue our graduation processes. At this time, we've been keeping them a year, and at that point, they're usually with an unlicensed personnel. They're with an MA at that point. And if the MA at that time identifies that the patient does have any new clinical concerns, or if they've been in the urgent care, ER, then that's definitely a red flag why we would be keeping them. But we look forward to incorporating more of our PAM results into the graduation process from here on out. For the higher activated patients, that would be an objective measure that they're ready for graduation, because they can navigate through the system and they will call us back if they need us. So we plan on using the PAM a little more heavily in that process moving forward.
Proximity is going to let Scott go next.
Well, and one thing too, since we started enrolling early, one of our goals to meet the enrollment goals was, well, to manage this many patients, we'll have to start looking at moving some on after meeting the 12 months.
Right.
So we built in a plan right from the beginning at 12 months where we review them for graduation. And as Kelly said, it is pretty subjective, but they are seniors with multiple chronic conditions. So it gives us an opportunity to evaluate where they are. And we found about 40% stayed in some sort of program, but you move them on to a disease-specific program maybe where your follow-up isn't monthly, you don't have the guideline, the guardrails to attend to. So you still kept about 40% of the patients that were in for a year, but you are no longer subject to the guardrails, so you can keep adding more patients.
Yeah, so lower intensity staff, lower intensity model, that makes sense. And we see that across our initiatives that somewhere between 20 and 30% of the patients maybe kind of stay in for a really long time, that they have enough fragility, low enough activation. I think there was Jan and Phil. Jan's here in the pink. Yeah.
We have acuity guidelines that we can use for any of our patients, and it kind of walks through an algorithm of how intense the contact needs to be. But that said, we have kept patients in the program trying to hit that 12-month mark, where they have used very little resources, if only the monthly phone call.
Which means there might be some opportunity post-guardrail to adjust kind of your graduation time length
Right.
In that. Because we do think of graduation as a big part of capacity creation. I think a few of you have mentioned now that the supply side is some of the challenge, and so having capacity created through graduation makes sense. Phil is in the table back there.
So what our initial intent was is to keep folks in for 12 months. We've modified that a little bit where it's actually they're able to maintain their gains for 12 months. So our STEP program, though, that we're developing right now will be if they maintain their gains for 6 months, then we'll drop them to a wellness coach with the RN supervision.
These sound like really well thought out, kind of disciplined, deliberate processes. I appreciate these. Aaron?
I just have a question. If anybody is using people who are succeeding in this and graduating, is anybody using those people as mentors for other people in an activation role? It just goes back to
peer mentors of, of
see one
successful
do one, see one
activated
do one,
patients.
teach one. Anybody?
Aaron, we're not using them yet, but we have thought about how could we incorporate the successful graduated members in a type of group visit and a group support system. So we're still tossing that around. Or even doing a group visits via Skype or something like that as well with our care managers.
But we had actually discussed on one of our leadership calls, and our case manager was really excited about it, doing a group visit for maybe one of the possible follow-ups on the care plan. So to group people that were diabetics around Christmas time and have them come in and do a little care plan about healthy eating over the holidays. And have people that, you know, sign up for it and then have an MA there, just grab some vital signs, make it a visit, make it billable for the physician so that they're getting it all over with at once for an hour on a Wednesday afternoon from 4 to 5. Patients are hearing other success stories, almost like a 12-step program. Hi, I'm Dara, I'm a diabetic, and, you know, my PAM score has increased. And that would encourage one another and increase patient activation.
That's neat. I really like that.
One thing that we've also done to encourage graduation, though, is I know Kelly's been working with the nurses that's the expectation, that the nurse is supposed to be transitioning these people through the program and not keeping them on, because we were finding that sometimes nurses would keep them on forever and a day. And by setting that expectation, then they set that patient up to transition also.
It's a great point that what we're trying to do is actually make people well enough so they don't need this intensive level of complex care management.
But at the same time, as we're talking about pop health and we need to touch as many lives, you know, we're kind of, you know, they kind of press that upon us. We need to, you know, we have 500,000 lives, we need to touch that. How do you impact utilization and touch a lot of lives at the same time? I mean, they kind of go, they don't go hand in hand when you're trying to graduate these people through so you can touch as many lives, but when you're trying to impact utilization, you know, I don't know, so that's a dialogue I'm trying, an internal dialogue I'm having when I'm going back to the executive team to say, I need more staff if you want us to impact utilization and touch lives at the same time, because we can't touch a whole bunch of lives and impact utilization, you know, with a limited number of resources.
Yeah, it's interesting, and be open. I think Vilma has a thought up here. As the mic moves, I'll say that what we're seeing more groups do, and something we're hearing here as well, is having different levels of intensity as people have different levels of need. And so then the lower intensity, lighter touch, shorter interactions, less licensed staff, with the less intense folks, which I think starts balancing. You may ultimately find you still need more staff, but that's sort of how people, I think, are balancing. Would be interested in thoughts.
The other thing with setting the nurses up with that transition is it makes their care plan more targeted. They're looking at specific things that they need to work on so that it's just not out there in Never Never Land. You know, that helps because that patient and that person have a target and they have a specific goal.
Right there, yeah.
Yes.
Sorry.
And my comment is very similar to yours, because I think for graduation to happen, you have a very clear focus for that member. You have a care plan, you have a set of intervention you intend to complete, you need to monitor the goal, how they're progressing with the goal, and if they are actually at the goal before you graduate them. But aside from that, you have to have a monitoring going on. And I see your point about referrals, because yes, that's one of the things that you keep your eye on. And we do have non-clinical staff monitoring referrals to ensure that if those patients start building up referrals, that before they get into trouble, the case manager who's had them before, we have a process of checking if a patient has ever been in case management, and they are referred back by the whole Department of Health Services. At any point that they are picked up, they check if the patient has been in case management and re-trigger that patient for a follow-up. I also wanted to address a little bit the issue about graduation or lack of graduation for some of the patients beyond 12 months, because my experience is that those patients that have very complex psychosocial, psychological, behavioral health issues, we had a tough time enrolling. So until this point, in fact, I think we have about 26 of them, Denise, who are still in service because of that weakness of the interface of behavioral health. So I'm waiting to hire my social worker.
You're sort of holding it together for them
yes,
in a way.
Because that was our lack of graduation at 12 months.
One of the other things that we ask, with the lack of graduation is, are you empowering or enabling? Are you enabling your patient to stay on and come back, or are you empowering them to make the decisions that they need to manage their care? And so if you're not graduating, are you enabling? If you are graduating, are you empowering?
Yeah, so it's a good observation that I think a lot of us will, and even will guide, that don't really worry about graduation until someone's in your lowest tier, your green tier. But then I think you're bringing up a good point that also look at people who have been in a really long time. What's going on with them? Make sure that we're looking to see if there's a function of the work that we're doing.
Yeah, and that's where Kelly does audits routinely on the nurses and says, okay, this person's been in, what's going on, why are they still here, what are you doing? And so we do the audits to make sure that that is happening. Because we do have some patients that the nurses want to keep for years. And it's like, okay, let's move on.
It also speaks to the pressure, I think, that goes to what are the objective metrics we can prove. And I think a lot of times with panel size, we can prove that I must be care managing this many patients, and that feels like a good objective measure, but maybe not the right objective measure in terms of the outcomes we're looking for.
I actually was going to add on to what Lisa was saying. It's actually like from the frontline staff point of view, a lot of times we do get the pressure from our leadership to keep those actively enrolled. And so either disenrolling them or graduating them, you have to go through so many hoops. Okay, why? What's the reason? Why? Do we have to? What's the reason? Why? So it turns around to say, forget it. You're healthy, we're going to just make it once a month, but we're going to keep you. So graduation or disenrolling becomes obsolete.
So the graduation thing here also helped to improve our shared care plan, because our goals for the patient were always embedded near the bottom. So in the new and improved model, the goal is now number one, because I wanted to refocus the care managers towards, this is patient-centered, it's not nurse-centered care. And we need to get back to having the patient drive the car instead of the nurse driving the car. And it really has changed everybody's mindset around the graduation piece. Because you're looking at that goal, and the 6-month follow-up care plan also has the goals, number one. So you're looking to meet these goals with the patients and actually centering the care more around the patient.
And then to answer your question, what we did is we added disenrolled to our dashboards. So not only do we have our enrollment that we show every month, but we also have our enrollment plus our disenrollment, so you can see over time how you've been doing with both. And so we split it out, but then so we can show that.
And we've heard some groups talk about unblinding internally as well, so you're seeing each other's, and there's a lot of value in that. Vilma, friend.
The other thing, too, that's critical to make sure that things are moving, for patients that are over 3 months in case management, we have a medical director review and a peer review process. So if it is a concern about a chronic patient who gets into trouble regularly and who seem not to really get under control, the case managers want to be sure that they are not closing these cases too prematurely, and that they wanted to be successful with those patients. So I think it helps them that there is a peer review going on and a medical director review before they close those cases. And then the other thing that I'm finding out is if you educate your patient properly, give them information on your contact, on ways for them to contact you, that if they get into trouble, they surely will contact you because they have your name, they're established with you, and it's a good way to feel comfortable that if you graduate them, you'll be able to get them back in if they need help.
Yeah, there's almost a graduation checklist I can see that comes from that. So this is great to hear how you guys are being deliberate about thinking about it and some of the challenges. As we move to the next topic, one last thought, we're not quite at a big number probably in any group that's graduated. It would be great over time if you are able to then look at some data of patients you've graduated and how have they done a year later. It'll help inform whether you're graduating at the right thresholds.
So the VR12, with our assessment schedule, the VR12 gets completed at intake and then 1 year. So we have fewer patients that have follow-up VR12s. But even given that, we have more than 2,600 patients that have both baseline and follow-up VR12s. And as you remember, the VR12 has 2 component summaries. So there's a scale for a mental health and physical health component summary score. And what we saw was improvement in the mental health summary score of just over 3%, from an average score of 49 to just under 51. And in the physical health component, more than a 4% improvement from an average score at baseline of 31 to an average of 32.3. And as we'd shared with you in leadership meetings, even though these changes don't look like much from baseline to follow-up, they really are profound, because remember, in the patient population that we're dealing with, where we have seniors, and particularly seniors that are frail, elderly, and with multiple chronic conditions, you expect to see a year-over-year decline in these VR12 scores. And not only have your efforts stopped the decline, but we're actually seeing slight improvement in the scores year over year in this population. So, and we also wanted to share with you our PHQ results, and we have at this point almost 4,000 people that have completed baseline and at least one follow-up PHQ. And the PHQ, much like the PAM, provides both a quantitative result, and we saw quite a profound change. Remember, the PHQ is scored so that a higher PHQ score indicates more severe depression. So the direction that we really want to see is those scores going down, and that's exactly what we see. So an average score at baseline of 4.9 drops to an average score at follow-up of 3.4, and that's a whopping more than 30% improvement. And the PHQ scores can also be categorized according to more severe levels of depression. So looking at the bar graph, going from left to right, we're going from less severe to more severe depression. And what we see in kind of a dose-response relationship is, across the board, at follow-up, more people reported mild depression and less depression at follow-up at each of the higher depression level severity categories. So once again, we're showing changes and looking at the changes in a couple of different ways here.
So Rob, can I ask a question? I think around in 2007, we did a community-wide depression initiative using this tool. What we saw was, we originally got a huge improvement that had to do with seasonality, and that's maybe less of an effect in San Diego than it is in Humboldt County, where I used to live. And people in Seattle, it's probably year long. Is there a sense of this, were the pre and post generally done same time of year? Because that's what we found out. The huge determinant of PHQ is what time of year it is.
We haven't looked at it in terms of time, but we certainly have the ability to. And I do want to point out, when we're sharing this data with you at your individual organizations, we note that there are differences in the patient populations that you serve. So not everyone starts with their patient population with an average score of just under 5. So there are more and less, your enrolling cohorts maybe have different results. So you're working with slightly different patient populations. And we try to point that out in your leadership calls when we're sharing your individual data with you.
Any thoughts on the PHQ-9 observations or the VR12 ones that preceded this? We have a few more minutes left in this session. Scott? Yeah.
How did you compute this, Rob? Was it from first one to second one, or first to most recent? We've had so many people that would have had.
Yeah, multiple at this time. With the PHQ, the assessment schedule kind of depends, and you're free to give it and administer it as often as you like. And what we've done, just as our methodology, we looked at the baseline score and compared it to the patient's most recent score. Yeah, so, and you know, one thing we've talked about doing is actually having a graph that shows baseline, and here's the first follow-up, second follow-up, third follow-up. We'll share that analysis in July.
Other thoughts on these two measures? Yeah, Dr. Shah.
I mean, as you get more severe depressed, people who tend to be Reds, we found that really they're just bored and lonely, and have somebody call them is really what they really want. And it does keep them out. It works. You know, obviously, people who are mildly, they're ones who are just starting to get sick, and they're probably not happy about that. And so, I mean, when we do our home visits, we have doctors and nurse practitioners, and we have nurse case managers, but I go and do my thing. It takes 5 minutes, but then the social worker takes an hour, and that's what really makes a difference.
Mm-hmm. That longer discussion with the patient, that being there with them, helping them work through whatever may be their challenge.
And that supports our hypothesis in seeing this, is that, you know, in a senior population, isolation and loneliness are real problems, and one of our tenets is to develop a relationship and a longitudinal relationship with a patient, and we hypothesize that that's going on, and that's kind of driving some of the results that we see. One last thing I wanted to point out here is that 22% of the patients actually moved to a less severe category of depression, or less severe depression level, too. That was something interesting in our findings as well.
The other interesting thing is that 0 is still mildly depressed.
Other thoughts? PHQ-9, VR12, general observations on the data string. Is this the last? This might be the last data slide itself. So yeah, Christian.
Just one thing on the PAM. So our group is focused on Medicaid population, and we found for those that surveyed on the PAM that most were in the higher level activation, level 3s and 4s. And so, which was kind of interesting, and I think that speaks to what we found in our population of resiliency, and also activation around getting connected to all the different types of services that they need to get connected to. So just something that we're interested in looking at further.
Yeah, and again, reasons to look at the data as frequently as you can, because you find things that might actually change how you work with those patients if you know that they're activated like that. Whereas maybe the hypothesis could be they are not activated, in fact, that they're the ones that are difficult to engage. Brenda.
And I think that just really spoke to the population, the really high acuity patients that we were serving, and how they were really not activated because they were so sick. Mm-hmm. And so that, I mean, because we were using risk scores to actually identify these patients, and they were really high risk scores. So, I mean, I didn't find that particular measure effective for this population.
Mm. Other thoughts? Good discussion. I think what Rob, you have on the slide makes, that first bullet is the one we've really reinforced across yesterday and today. The metrics matter, and they matter more than I guess the way I see it, and the way you and I talked about it earlier, was the metrics matter more than just what that data point is or just to collect the data, but it's actually to translate it. And I think you guys have been saying that across the last 24 hours, that translational value to make you do something different, to have an observation so you change a process, so you learn from the patients that you're managing. And that's really neat, and that's been a neat process in IOCP.
I think we had such rich discussion during this topic this morning that I don't think we even want to dive into how you measure success. We left that on as some filler time for us, and we had such rich discussion going on that if we launched into this topic, I think that, yeah, we'd be here all day.
So I think there's an impending break, if I understand that right.
I'm Diane Stewart. And actually, before we start the afternoon session, I just want to just make a connection to something that was raised earlier this morning, which is the PAM instrument, and about half of the people are planning to continue it and half aren't. For those of you for whom finances is part of that barrier, Scott, can you raise your hand? Scott Larson is from AstraZeneca, and they have an existing relationship with Insignia, and might be able to support some groups who want to continue on it, at least as a transition plan. Did I get that right, Scott? Yeah. So that's one reason he's here, because we had heard from you that was a problem for Pam. So I just wanted to call that out. So for this afternoon, we're now going to talk. We've talked a lot about where we've been and what we've learned from that experience. We're now going to start with how we expand the model and where we're going. I'm going to start with what PBGH is planning to do next. Then we're going to hear from a couple of our partner groups about what they're doing, particularly as they think about ACO contracting and what role IOCP is playing in their care management. And then we're going to finish with what we can all do about making the model more available to patients across all business lines, so to speak. Comes back to the sustainability question we started talking about this morning. So let me start with just some data. We've been focused on the Medicare population, and it's just been fabulous listening to what everyone is doing and learning. It's just been an amazing morning. But I'm going to use this slide to just tee up what we're going to now start to think about this afternoon, which is, this is, a national agency does this kind of research. And what is the distribution of patients who are in your top cost 10% over at least 2 years? And you can see that actually fewer than 50% are over 65. That's the population we've been focusing on now. But look at all these other folks that might be able to take advantage of this care. So let me ask you, how many in the room are managing high-risk commercial patients right now? Okay, we have some. How many of you are managing high-risk Medicaid patients right now? Okay, a couple, 1, 2, maybe, okay. So part of what we'll talk about is how can these models be adapted for other populations, and what are some of the sustainability issues there?
So can I ask one other question? How many people are managing high risk, undocumented or uninsured?
Yeah, some degree, yeah.
Because there's a
back.
potential business case around that too.
Yeah.
So.
Okay, so the next then is, what is PBGH doing? And we really want to see multi-payer alignment across all population types. We're going to come back to that after we hear from St. Luke's and Scottsdale. But this is kind of what's happening next steps. So with this group here, we already have another session planned on September 24th that would be open to all of California, where we're hoping to showcase some of your work, and we're just starting planning about that. It might be a chance for all of you to come back together again. And then Tim Chafin, if you want to raise your hand, is compiling a best practice guide. He was telling me about what he's been doing over the conversations we've been having this morning, which is madly taking notes. And we will have that available and send that out to you when that's put together, so you have the benefit of learning from all the groups that have participated in this program. And then on the commercial side, so from PBGH, those of you who don't know us so well, we're a membership organization of large healthcare purchasers, and they include Walmart, private purchasers like Walmart, Wells Fargo, Intel, as well as public purchasers like CalPERS and University of California and Covered California, the exchange here in California. And the reason that they thought it would be a good idea to apply for a Medicare grant is to make these kinds of models more available for commercial patients. One of the things we learned early on when we did a little pilot with CalPERS patients is that providers really don't want to just manage a small number of high-risk patients. They really want this kind of support, that it's much easier if it applies to all patients. And there was very little we could do to say, just for commercial patients, use these resources, unless we were also working with Medicare. And we know from talking with each of you, about half of you seem to be working with commercial patients right now. So what's PBGH planning to do next in regards to this? I think our members see that the high-risk care management is probably best embedded within an ACO product. It may be what you all are seeing as well. Let's come back to that question after we hear from our panelists. And so what are the supportive payment models that allow that? Obviously, HMO product allow that. Full risk capitation allow for sustainable models. We've had discussions with both Cigna and Anthem, who at least in California are offering tiered payments to physician groups or healthcare systems to manage either ACO or even high-risk PPO members. Our members are trying to understand whether these really work, whether they work for you, they are paying more for these products. So they are paying for these ACO products. And so a next step for our members will be some process review, which is taking a look at groups that have the Cigna and the Anthem PPO products to understand, is care really different on the ground? And it wouldn't be just, we might choose some, quote, IOCP groups, we might choose some groups that are not IOCP groups to see if care is really different. So that's a quick snapshot on sort of the commercial market. Our members are interested, I've had a number of discussions, are our members interested in direct contracting with providers? Very few are. Most of them that Intel, Boeing, Disney may be interested in doing some of this. Most of our member companies are going to be working through their health plans simply because of bandwidth issues within the benefits departments. So most of what our members are doing around the ACO products and building out the commercial is going to be through the health plans. But I'd be happy to answer more questions about that if folks, if you have them, maybe at the end. And then finally on Medi-Cal, at least in California, the state of California has decided to go ahead and take advantage of a program that's in the ACA that allows the federal government to pay extra funds to manage high-risk Medi-Cal patients. And I don't know if that's in any of the other states we have in the room. It's a 2-year program. So the state of California will be taking advantage of those payments. It's called Section 2703, and it's one of the reasons we have CPCA in the room with us today and Hunter Gatewood, who have been working on these programs already in the safety net. And PBGH will be leading the technical assistance. So in another year, we might have a room like this, but it would be different kinds of delivery systems who are working on managing high-risk Medi-Cal patients. So some of you in the room might be interested in doing that, which you should know about. It's going to be starting in 2016. At least the payments are right now planned to start in 2016. We know in working from the state that everything is a bit of a moving target, but that's the current plan. So we're beginning to see alignment across all product lines. Spotty, not complete, and we're going to come back and talk about what the implication is for you. But that's kind of the very tactical next steps that at least PBGH will be doing in the coming year. So with that, I'm going to pause, and now we're going to hear what two of our groups are doing.
We'll go ahead and start with just a little bit of introduction about St. Luke's Health System here. So we're located in Idaho, the southwestern portion, and I know when speaking with Tim Chafin earlier this week, he was asking about population density in Idaho, and it is not dense at all. But you get to see a little bit of, we range, I guess maybe that doesn't work. So we range everywhere from the eastern portion of Oregon there down farther into southwestern Idaho. We've divided ourselves into two regions. Our west region, which encompasses Boise area and over to Oregon, and then the eastern region, which is more kind of southeastern there, as you can see. And so I'm actually aligned with the east region. And just to give you a little bit of size and scope, so besides just some of the numbers that are up there on the slide, we are really part of two major health systems in the area, as well as then some other independent hospitals and smaller little systems. About just over half of all healthcare claims and expenditures in the state of Idaho come through St. Luke's Health System. And for the East region, we're really about the only major player in town. There are about 85 to 90% of clinicians are contracted, usually independently with St. Luke's, but there are just a small number of providers that are outside of St. Luke's Health System purview where we're at, which is good and bad. It has helped us somewhat in our communication strategies. We all, at least in that region, we utilize the same electronic health record. We actually, between the east and west region, we are not on the same electronic health record, but are moving that direction in the perpetual 2-year model. So I started there 7 years. Started there 7 years ago, and it's been 2 years ever since. But I think we are actually making some progress towards being unified in our electronic health records. So about 3 years ago, 2012, St. Luke's made the decision to enter into an accountable care organization. We opted for the one-sided model, a little less risk, less upside if we did well in it. So we have just, as we have been deciding recently whether we're going to reapply to be an accountable care organization. These are some of our latest we've had. And so on those 33 measurable metrics that they have for the accountable care organization, these are some of the major changes that we've noticed. And so we've done really well in some areas. Here's maybe then the bad side of things. You start to look and measure. I don't know how many of you have read The House of God, but you know, if you don't want to find a fever, don't check for one. And that's maybe a little bit what we've gotten ourselves into, is saying, all right, so we start to measure and we learn. And so just to show that it's not all good, we've had our eyes opened and we've found out that maybe we don't perform as well. Most of the other metrics, we were within a small percentage point of where we started, and so really no change. So the good is where maybe we've seen big changes, and then the bad where we've seen big changes in the wrong direction. So then the question becomes, is it worthwhile for us to participate in an accountable care organization? And so we question how much we are actually getting from a savings standpoint, where we have, you know, that first 2.5% off the top goes directly to Medicare. Actually, in our region, we actually manage our members fairly well, and so we were already at about a $7,000 per member per year spend, which is pretty good nationally. And so we look and say, how much money are we going to actually be able to shave off of that? And really we see, as with most things in Medicare, we say they dangle that carrot out there, and pretty soon that becomes the new benchmark. And so we see any cost savings probably diminishing or going away in the future as we get down to the standard of care is well-managed care, and so you better be up to snuff. So we have actually decided that we are going to renew for the next next 3 years as an organization. And this is just to show maybe where our IOCP program fits into our accountable care organization. Our IOCP is called Co-Partner Care of Patients at Risk. And so this just a busy slide here, but just shows there's a decrease in our per member per month spending. And then the bottom bars there, if we look at the top portion of the bottom bars, that's our managed risk group patients, where we have decreased ER visits on the left column, decreased inpatient visits on the right column, compared to the bottom bars represent patients at risk who are not managed in our IOCP group and have had an increase in their ER visits and inpatient hospitalizations. And then this shows where we kind of see IOCP fitting into our accountable care organization. This is much similar to what Pranav presented yesterday with our build, measure, learn kind of cycle. And so this is our organization's representation of that. And really what's been beneficial for us as far as participation in an accountable care organization has been that it has caused us to measure and learn, and we feel that participation in this IOCP grant and program has much discussion, as we talked about those guardrails, maybe helped us out to define what we want to be doing, and then we would see ourselves maybe in this 8 o'clock position here. This is where we implement our population health management strategies. And that would probably be the other lesson that we have taken away from participation in this IOCP is that our IOCP we really had very limited population health management strategy when we began this journey. Our West region had already been managing some commercial patients prior to participating with PBGH. But our East region had not done anything like that. We had some little offshoot programs, but this caused us to look at things, and this is our organizational structure for if this bar here underneath represents our population health management strategy, and our IOCP fits right here, and it's part of a broader health strategy. So we had some things going on with wellness. On the far spectrum, we have maybe hospice, but then we've also developed some palliative care strategies that we didn't have robustly in place, as well as some post-acute care services and some transition services as well, so that readmission type service. And so we really feel that the IOCP has helped us to fill in some of those population health management gaps. So as far as for what I would say we have taken away in St. Luke's Health System from participation in an ACO is this being able to benchmark our progress nationally against other people has been good for us to see where we're at. We also still would have to be participating in the PQRS system, and we'd have to do that independently. So this just gives us a way to do that as part of a roll-up solution. And then really we've looked at this once again. This comes back to that valuing, how do we measure our value? And although we have been able to show that our IOCP program has been successful in an ROI type situation in decreasing our per member per month savings, once again I really feel that as we move that bar down, the expectations will also come down to meet that. And so we really view the savings as short term. And what we feel like we've gained is the ability to manage populations. This has been a good chance for us to experiment and learn how to risk stratify patients and then match appropriate resources to that risk stratification. And then from participation in the IOCP, once again, filling in that kind of one of the gaps that we have in our population health management, and then certainly has been an influence in our other population health management strategies, helping with a template, some of those guardrails that we've put in place. We've utilized that across other population health management strategies. And then the new chronic care management codes, we've started to utilize what we've learned through IOCP, and actually in the West region, just within the last month or two, have started to build out chronic care management codes in that regard. And then has been brought up previously, certainly the goofy economics. Are we saving money, or are we costing our hospital system money because we have decreased our ER visits and inpatient visits? And sometimes the message from our CEO is, great, we want to do this thing, and then we talk to our finance people and they just don't get it. So this is kind of where we're at with St. Luke's.
So I am also going to set us up a little bit on, just so you can understand who Scottsdale Health Partners is, because healthcare really is local. And what has been really cool about this experience with PBGH is really looking across a couple different states and really working with all of you and realizing that there's similarities, but there are a lot of very big differences. One of our big differences is what is Scottsdale Health Partners? How do you classify it? We're not a hospital. We're not an IPA. We're not an insurance plan. We're a clinically integrated network. And we really formed we started in 2010, and basically it was the hospital system bringing together some independent physicians, both specialists and PCPs, together to figure out what are we going to do to help coordinate care, and we really didn't know what we were going to be. To purely understand this, you need to know a little bit about the history, which was that Scottsdale Healthcare was a hospital system of 3 hospitals that is really locked in the Northeast Valley or Northeast quadrant of Phoenix, and pretty much the only hospital system other than Mayo in that area. And you have a lot of fiercely independent physicians there, a lot of onesie, twosie doctor practices, some group practices, but a lot of physicians who wanted to maintain independence. At that same time, we've got a lot of big hospital systems in Phoenix as well who are going through, the consolidation that we're seeing right now of employing a lot of the physicians and buying practices and things like that. So we came together not really knowing what we were going to form, and we ended up coming up with a joint venture that is 50% owned by the hospital and 50% owned by the physicians. And it was the other reason that we had to do this was back in the 90s, before my time, that in the 90s, the hospital system had a failed PHO. And so there was a number of physicians who were employed, bought into this, and then they lost a lot of money when they divested. And so there was a lot of mistrust of the hospital system at that time period. But we came together with a common mission of really transforming patient care, and we kind of sit as a joint venture that's outside of the hospital system, but includes the hospital system. And it is a board that's made up of 6 administrators, 3 PCPs, and 3 specialists. This was something that was also a little bit different about our system when we started, was really including the specialists. We know, and we found out that the specialists also agree that primary care is the key to great population health management, and having the specialists get on board, and then also supporting the primary cares has been very valuable. This is just a makeup of ours. So we started out with about 400 physicians, and our physicians had to buy into this. They each had to pay money to join. We've got quite a range of specialists, and we're now over 600 providers. So we started out not being an ACO. We started out wanting to be a clinically integrated network, and because we were a little afraid of the government and what are all the regulations that are going to go along with that. And so this is kind of a summary of our plan. So we kind of go across all. We have a Medicare now. We did in 2014, we became an ACO. We've got some Medicare Advantage plans. We have a commercial plan, and we have a direct employer plan with the hospital employees. And over that, actually, I think we're over, this is a slightly old slide, but I think we're over about 30,000 patients now that we're managing. And what are the secrets to our success? Multiple. One, the one that's not on here, but I think I'll go through these and then I'll say the fourth one that I didn't put on the slide, but physician engagement has been extremely important, and it's something that I hear that everybody's struggling with. And we haven't had as big of a struggle with physician engagement. And partially, that's because all the physicians had to buy in to be part of it, so they were engaged in the beginning. And I don't know if you noticed, whenever I introduce myself as a practicing physician, and I think that that is key. I think that having physicians who are practicing, who truly understand the day in, day out challenges that are going on is really worth its weight in gold when you're trying to engage physicians. So we don't roll anything out without me piloting it in my office or in somebody who's kind of on board. And so firsthand, I can see what are the problems with the model that we have rolled out, as well as being able to help people when I'm going out and discussing that. So we have spent a lot of time on physician engagement, and we do that in multiple ways. One is on a quarterly basis, we have physicians who go out to each of our PCP practices to talk about their patients, to talk about some different initiatives that were going on. When we are rolling out the IOCP program, it is a direct physician communication that goes out to get people involved in this. And we do that. We do also all member meetings, and our all member meetings are attended far more than our med staff meetings. So we get probably about double the attendance of the physicians than the hospital system does, because I think they find that it's valuable and we're delivering information that's valuable. And then we also do some communications. The other thing that goes along with our IT that we've done for physician engagement, and some people have heard me talk about it, is communication between physicians. And so we utilize a Tiger Text, which is a secure texting solution. And this has been very instrumental in the success of our IOCP program, because our care coordinators can get a hold of the physicians in an asynchronous fashion, and they're communicating. And it's actual true communication, not read through my 10-page note and figure out what I was trying to say. And this has been super helpful for that, but it's also been helpful in physician-to-physician communication. Because if yours was like ours, previously I had to dial up the phone, get the front office staff, see if I was important enough for somebody to be called out of a room, and then maybe I get to talk to the physician about another patient. Now I can be in a room with a patient, pull up Tiger Text and text the specialist, and by the end of the visit have an answer back about what we are doing. There's two different versions. They have a public version of Tiger Text, and they also have a network version of Tiger Text that we utilize. So we're able to monitor it. We've got staff that administers it, and it's been very helpful. It's password encrypted and things like that, and so it's been we haven't had a problem, and it's been hugely helpful in communication. And so thank you for bringing that up, because one thing that we've noticed when you deal with the hospital system is there's a lot of legal things that you can say, and it automatically shuts down a program. So you bring up HIPAA, you bring up Stark, or you bring up something like that, and then automatically we're not going to do those things. And so being a little bit outside of the hospital system has allowed us to be more agile and really think about what truly would be helpful to our outpatient physicians. And being able to have that instant communication was helpful. We are different than St. Luke's in that what a lot of systems are doing is trying to go and get everybody on one system, which is awesome. We knew that was totally not something we could do in our place. We have about 28 to 40 different EHRs that people are using, and they've spent a lot of money on it, and they work really well. It works for their workflow. And so trying to get all of those physicians to change over to another tool was just not going to happen. So what we did instead is figure out how can we communicate, and that's where we had Tiger Text. The other piece of it is a health information exchange that we've put in. This is our technology stack that we've put together, and the main piece is that communication and then that health information exchange. And what we did is say that what are the main pieces of information that everybody needs to know? Let's start there, start small, and then we keep adding. And so right now we've got lab data, we've got radiology data, and then we have hospital data, a lot of the hospital reports, and then we have ADT information, so admissions data, admissions, discharges, and transfers that goes into that. And that's something that all of the physicians can see and the care coordinators. So it's been helpful for our care coordination programs because they're now everybody is seeing a view of that patient that is very similar. And again, it's one of those things that we've been outside of the hospital IT because right now our hospital is trying to go through converting to an EMR, and there's no way that this would get we would get no airplay at all trying to do something like this. So being outside of the hospital system and being able to go and just charge through with getting this HIE done, we were able to do it within 8 months, and we would be on that perpetual 2-year cycle if we had to rely on our hospital system. So that for us has been a huge thing that has been helpful, is really looking at meaningful technology that matters. Go back just a second, because why we are all here is care management program. And this is something that actually we were, if I remember back to when we heard about PBGH, we wanted to start in wave 1. We were like, get us in, we really want to get in. And we didn't even have hardly a system at that point. And so the success for us for PBGH is it gave us a program. We knew this was the model that Karen and I put together from the beginning. Was we know we need transitional care management, we know we need care coordinators in the office, but we didn't have the structure behind it that PBGH was really allowed us to do. And so really it is the basis of our program for our care coordination. When we started with transitional care managers, and then that were in the hospital, and they see all of our patients, any SHP patient that gets into the hospital system. And now having the care coordinators, that team is super strong. And so anytime that we have it both ways, so if there's a patient that is eligible for care coordination that's admitted, the transitional care manager will enroll them into the program and get them set up with a care coordinator. Likewise, if the care coordinator has a patient that's going into the hospital, they will let the transitional care manager know, hey, this person's in the hospital, and they'll have that conversation. And really, we're utilizing those people to help keep the PCP connected as to what's going on, and kind of as that extension. So we saw those 3 things as really the basis of our program and the basis of our success. The last secret to physician engagement, it's money. I'm a family practice doctor, and I'm all about doing the best thing for the patient, but I can't do that if I can't keep my doors open and I can't keep my staff paid. So the thing that we did, the way that our financial system is set up for our providers is they're still all on their own fee-for-service contracts, and then SHP is kind of a layer on top of that. We felt that it was so important in the beginning that it was part of our tenant that when we started that the primary care would get a care management fee, because we were going to ask them to do a lot of work. We're going to ask them to do quality. We're going to ask them to do additional outreach. And so we have committed to our primaries that we will give them $5 for commercial payments, or for commercial patients, and $10 for Medicare patients as a care management fee. And that, a lot of the initial capitalization money that went in is going towards paying those care management fees. Now, what we do is we try to negotiate those in with our payers, but if we don't, it's still something that we commit to our PCPs. Now, as the panels are getting bigger and it's a significant amount of money, we might be able to dial that back a little bit. And then the last piece is that gain sharing, which we have not had gain sharing yet that we've been able to distribute out to our providers. That is one lesson. It takes a lot of time to get there. Because you've got to pay off your operations, it takes a lot of time to even figure out who your patients are and then to make a difference. So my last piece will just show you some of our success. So this is our transitional care management program, and they're pretty busy, and basically our average readmission rate has been 3%, which we're very, very happy with. We do have some early success, and we know that we have decreased costs for our Humana Medicare Advantage patients, about 10%. We've also showed it, we had an increase in our STAR scores there. And then for the employee plan, that we also showed a decrease in about 10%. Now, both of these, another lesson learned is both of these are places where we get true claims information, and we're able to use that and put it into our risk management system. We also have a plan with Cigna, which we had some savings, but it was not as much. And so what part of the learning that we have is that we need to get true claims data in order to be able to be as successful as we have been, because you utilize that to figure out who are your high-risk patients, who do you need to concentrate on, and really who are your inefficient providers. And so that's one of the things that when we're looking at with our insurance plans, we make sure that they are going to give us the claims data.
So questions of fact or things needing further explaining?
So on your care management fee that you return to your physicians there, that $5, $10, is that a one-time fee? Is that a monthly fee? Is that an annual fee?
Yeah, so we pay it out quarterly. Yeah, so we pay it out, on a quarterly basis. When we go out, we bring them a check, and then we also bring them a list of things to do. It works really well.
Yeah, I like that.
So it would be $10 a month for 3 months, or $10 for 3 months?
It's $10 a month for 3 months, and then per member, and it's almost everything is done on a member month period.
Okay.
So if it's not all or none for a quarter, we measure it on a monthly basis, but pay it out quarterly. Just a word about that, and something that you should know, if you're starting to get into commercial plans and even the ACO, a lot of these are attribution models, especially in Arizona. We don't have as much capitation and that type of thing. So a lot of them are attribution models. So we have one plan that we went live in January of 2014. It wasn't until May of 2015 that we got a patient list. And so
That's this month, by the way.
yeah. Exactly. I mean, it's ridiculous. So it's sometimes, it is something that is important to let the insurers know when you're trying to tell me that I need to save money. Well, I kind of need to know who those patients are. That's kind of, basics. We really need to know that. And so we got a little bit smarter in our contracts of saying, there's certain things that we need to do in order for you to get us to that place. The one other thing I'll say is that none of our contracts are downside risk right now. All of ours are upside risk, only shared savings. We have a couple reasons for that. We're not that big. We don't have a lot of money. If you have a lot of money, you can probably go to downside a lot quicker than we could. But also because of the history, a lot of people didn't want to get into downside risk right away. And so we kind of had this risk glide path, which is we want to make sure you're going to give us our data. We want to make sure we're going to be successful. And then once we can get shared savings, then we will migrate to risk.
So question here. Yeah.
So a couple questions just to clarify. Were you guys were a CI network first and then you became an ACO, or you
Yes.
started? Okay.
Yes.
And then, because I'm in a CI network, and it's, when you said, 38 different EHRs, that's what we're living in. It's really challenging. So can I ask, or I'll accost you later because I have lots of questions, for some of the requirements to report on the quality metrics? How did you all go about doing that with so many disparate systems? Did you use claim upload, random sampling?
It's very interesting when almost all of our stuff is decentralized. So when we have to send out, for the ACO program, you have to do a couple things. One is send out letters to all of your participants. We actually distribute that list out to the practices and have the practices send out their list, and we don't pay them their care management fees until they've sent that letter out. And then for all of our quality data, we used our HIE first to see what gaps we could close there, and then we basically had an Excel spreadsheet that went out to each of the practices with their patients, and they all did their own reporting. And yeah, and they were that they were engaged in doing it, and it was good. Now, there were some people that we had to pull some more teeth with, but the majority of the time, they're very helpful. And we also utilized our care coordinators to do some of that work as well.
So a question on, is there a P4P program separate from the management fee?
No, the way that we have it structured, as far as payout to the physicians is, should we get gain share, that there is a door opener. You have to meet certain quality metrics. And then for the PCPs, it's dependent on their panel size as far as how much that gain share would be. But in some of our contracts, we do have P4P incentives that end up going back to the organization and are utilized then to pay out those care management fees.
Okay.
Can I ask? Oh, go ahead, Jenna.
That is all by the initial investment that the physicians made. And so how much was it? It was $3,000 to start out with, and now it's up to $3,500 per physician. It's a one-time fee. So some of it, obviously that's not sustainable forever. So the hope is that that is utilized until you get enough money back in by your successes.
Can I ask one more about your HIE? And it might be on here, when that started, and was that solely paid for by the CIACO? Was it mandatory the physicians be in that HIE, or is that part of that $3,500 fee?
Yeah, so the other part of the structure is that a lot of the IT and that type of stuff comes out of, you probably saw that management services organization through the hospital, which is basically set up kind of like a loan to SHP. So we manage it, they are paying for it, and then we have a loan that we pay back to the hospital. So the HIE, we don't really make anything mandatory, because I don't find that works very well, especially when you have a ton of independent physicians. We try to encourage them by doing things like citizenship points, and then also making sure your tools are useful. And so that's one of those things that I would say every physician, talk about testimonials about IOCP, we certainly have those. We have tons of testimonials about the HIE and how easy it is to use, and that they found information that they couldn't find elsewhere.
Do you want to move to California and come?
So let me kind of leap in and draw some commonalities and then kind of frame the conversation, because the topic ahead of us is different payment models that allow us to continue doing the work of the last 3 years. And what was amazing in the last 3 years was, like 2/3 of the patients that we had in IOCP were part of Medicare Advantage. A third were not. And people, it wasn't like we were paying you a lot of money to do this work, and you still did it. And the thing that's so striking about both of your stories, and I do have questions about the competitive market in Scottsdale. There is no competition in where you come from, Aaron.
Directly where we're at, in Boise areas, but
yeah. So this gives me hope for American healthcare, basically, these conversations, because it's communities coming together for the betterment of the health of the community and the betterment of the life of the providers. And they're willing to kind of let you have some of their money to do the things that they actually want you to do, even if they can't articulate it on the front end, right? And you probably both went through it, because you basically you didn't have this huge, gun to your head of, if we don't do this, we're going to go out of business thing. And, it's interesting for me because both Lisa Nedlin, sitting way in the back, and I, when I hear the Scottsdale story, it's essentially the Humboldt story that started in 1995, and, almost exactly. And again, without, I look at the managed care in Scottsdale, and it looked like on those numbers, and they're probably a little old, that there were like 129 lives in HMO, right? So it wasn't HMO. It wasn't HMO that drove this, right?
No.
And there's no HMO in Idaho, right? Or is there?
Not more PPO and
more than PPO. So again, it's, this is sort of a voluntary, let's integrate the community's healthcare system effort on both fronts. So my hat is off to both of you and the creative ways that you've done it. And then now you're kind of choosing to take on not a lot of downside risk, but at least put the toe in the water using ACO as the way to begin to have it, aligned incentives, essentially. And my guess is you do it even without that, is what I'm hearing, right?
Yeah.
Yeah, why? That's my question.
I think the why for us has really been what Tiffany spoke to, as far as saying we wanted to make sure that we were going to get the data. And I know for where we're at, we actually aligned with a new payer to Idaho, who came in partnering with St. Luke's Health System to be a fully at-risk contract. But we wanted to, even with them, who that was their purpose, is to come in and set us up fully at risk. It's taken us over a year to get data, and that's probably been the biggest reason. Is, once again, you can't deliver these products unless you know who you need to deliver them to.
Yeah. So there's a few things that I would say as far as the ACO. So I don't know if you guys realize how great St. Luke's, $7,000 per patient per year is an extremely low baseline, and we're not that low, but we're also fairly low. And when we travel in the ACO circuit and are looking at other, who actually made money in the ACO program, their baselines are $15,000,
Yes.
$13,000 and $15,000, and so that there was just. It's a different market, but there's a lot of waste that was going on, and so we went into the ACO product thinking, we thought maybe we could make some money on it, but after we kind of figured out where our baseline was compared to everybody else's baseline, we're like, I don't know that we're really going to make any money on this. However, what it did do is it gave us a big patient population to put our infrastructure in place. And so we knew that we are going to be more successful in our commercial plans and our Medicare Advantage plans, but you have to penetrate enough of the physicians' offices in order for them to get those plans in place. And so we think it's probably between 15 to 25% of the population you need to really make some changes. And a word that I will say, we've actually made the determination for our care coordination program, as much as I'd love to be altruistic and say we're going to do it for everybody, we can't, logistically we can't. And the other thing is you get into problems when you're looking at a commercial payer, because they will use your baseline as your baseline. And so you're comparing your really great self to instead of comparing to the market sometimes. And so you have to be very careful about rolling those out. If you're a hospital system, it's okay, you can do that because you are getting other benefits by, decreasing your readmissions, that's helping you with penalties and things like that. But if you're a provider system or you're looking at getting other contracts, sometimes if you perform too good at the baseline, that's who you're comparing to. And so it's a really delicate web you have to weave in order to figure out, what's the timing of rolling out these programs and who do you roll them out to.
And I would, along those lines, much what Viraj had brought up earlier about being able to leverage some of the infrastructure that you're building with this for commercial payers later on in negotiations. I think we were more optimistic that payers were going to engage with us earlier on. We felt that the climate was there, that was the way things were going. We thought we were going to have a lot more commercial contracts up front to be able to do that, and we've been a little bit surprised by how slow some of those payers have been to come into wanting to negotiate that at-risk contract.
And we haven't done it yet, but we're thinking about, because a lot of the payers have their care management services, and our care team interacts with their care team. So part of the strategy that we're thinking about is, can we get that delegated? So instead of that coming out of their administrative fee, then we can get it delegated so that we're not being charged for it and actually also delivering it. But more, that's for the future. We'll see how successful we are at that.
So, in terms of, in Idaho, you talked about a return on investment, which is a little over 1, right?
Mm-hmm.
Medicare gets the first 2.5%. So is that a loss the first year?
Yeah, probably.
And so how have you managed that?
One, I really feel blessed that we have good administrators at the top who recognize this is where we're going. Once again, that we really didn't feel like from our baseline we were going to make money in an ACO. We thought that it was going to help us learn how to get data, what was the process of taking that data and flowing that down to risk stratify our patients and match the appropriate resources with people. So just to do the population management, we felt like that was good enough for us because we still really believe that that's where the model is going, and we want to be prepared when it gets there.
The question before about, would you come to California? I'm somebody in California, and the work in Humboldt began as we were seeing managed care march up the coast, from LA to the Bay Area to further north, because Humboldt's up in the extreme north of California. And, we wanted basically control over that process, and we wanted data, and we wanted the right thing to happen. And we had, we did have HMO contracts which got our IPA off the ground, and very similar to your story. We didn't have the strong hospital, we didn't have the hospital system launching it, and they cooperated to some extent, but they were not. It was really what we did is what drove the thing, a lot of it was the same way. But we hit because of the HMO climate in California. It was very hard to have collegial relationships, and I remember going to one of the insurers who will go unnamed in California and say, please give us the list of the patients who were at high risk in 1996, right? Mm-hmm. And them said, no, that's our competitive advantage. We won't give it to you. So, and you're still waiting a year to get that list in 2015.
And I wouldn't say some of it is unwillingness to share the information, but more of it is just it's very difficult to get that information, especially there in Phoenix. There was a bad taste with HMOs, and so HMO, if you call it a HMO, people won't buy it and that type of thing, there's a lot of great things about HMOs. Number one is it really encourages a primary care physician, and it tells you this is my population. And so it's kind of funny to do population management when you don't know who your population is until after the measurement period. And so so part of it was a willingness, so we make sure that they're willing. But the other part of it is these attribution models are such that you have to have seen the patient 1 or 2 times. It's whoever's seen them 1 or 2 times. And if you're doing really great care management, you might not need to see them 2 times. You might be seeing them 1 time for a codable visit, and then being able to maintain some of that stuff other ways. And the other piece that we have is we have tons of insurance companies in Phoenix, and so people change plan to plan. And so it's your patient. They've been your patient for 10 years, but they've been on 5 different plans. And so some of that has been just been challenging.
So given the that you've both made this, that the organizations have made this investment, and what's really pleasing from an IOCP point of view is that it sounds like the model here has been what you've done. What I see in both of you is like a lot of effort at segmenting the population and designing programs for different segments of the population. What's the process of doing that? How did you, most people start with, we'll do care management, one size fits all. Mm-hmm. So can you tell stories of how you got so smart so fast?
Started in my mother's womb.
Don't go back that far.
So I remember, so speaking of kind of that transitions from the hospital to another downstream care setting, we had our IOCP program in place there, and I remember talking with my care managers about saying, hey, is this something you feel like you can do? And I just remember the deer in the headlights look of them saying, boy, that's pretty intensive to be able to deliver on that sort of a intensive in their home that frequently after being hospitalized, visiting them in the hospital to help set that up. And they were already doing home visits from an IOCP program for that initial super visit. So they were there and they knew them, but to do the additional work, it was one of those. So that to me was the story of saying, in my mind, I thought from my patient's perspective, they would like to see me everywhere. They want me to see them in the emergency room. They want me to follow them to the hospital. They want me to hold their hand with them while they go home. I mean, in their mind, they want one person. And so I think in this ideal world of, whether it's, if we could simplify the care of, all right, you have one person who's assigned to you, and so that's what I was thinking when I was approaching my IOCP team about this and saying, hey, that would simplify things. It would be one less handoff, but the deer in the headlights look from them. I said, okay, we're not going to, whether it will help. And so I think, I think of our palliative care services when, once again, I remember the first time hearing about palliative care as a specialty, and I thought, well, I'm a family doc. That's what I should do. And then as I start to go, oh, but you mean I've got to spend an hour and a half to 2 hours calling family members and doing, yeah, they're like, okay, no, that's not what I have to do. So I think it's been that for us as I've still kind of kept in my mind of, I want to do it all because I feel like I should because I'm a family doctor first. But then as I get that gestalt of the deer in the headlights, oh no, I can't do that part, I go, oh, there's maybe a natural break point. We need to give some additional help and support and services.
Tiffany, can you talk to that?
So first, to answer your question, that's where we did have a little bit of technology that helped. And so basically for our transitional care managers, it was if the patient is if they identify their PCP as a patient of any of our physicians, and actually they are in one of our insurance plans, that's a trigger. So those are the transitional care managers patients. And then when we set up the IOCP program, it was, we have embedded care coordinators, and we went out with a high-risk list of patients. We actually found that, that was helpful, but really having the physicians identify their patients was way more beneficial, and it really helped with buy-in. So it was a good place to start, but it wasn't, but really having the physicians identify those people. And a lot of times as a physician, when I was seeing patients, I wouldn't necessarily have thought that somebody was a good candidate, but then I see them in my office, I'm like, oh, I got a great program for you. And being able to have that person right there has been helpful. I would say, and I'm maybe like you, which probably a lot of doctors are like, feeling like, oh, I got to be everywhere. But what I've realized through this is my patients actually don't really necessarily need me to be that person all the time. They just need to know that I know about it. And so name dropping is so helpful when you are, and when it's actual, it's even better. And so when they, so when they, when our care manager would go in and say, I've spoken to Dr. Nelson, or I'm letting Dr. Nelson know what's going on, and they actually are, it's like, ray of light, like, this is great. And so they just start to see your team as an extension of you, and that makes me be able to do so much more than I could ever do if I was just myself. I'm sure that most of my patients probably love my MA, my care coordinator, way more than they love me, but I get all the props as well because she's so wonderful. And that is something that, unfortunately, it's probably an expectation that patients always had. They thought we were talking, and we weren't. And we were trying to just do it by getting notes, and getting notes is not communicating. And so that Tiger text and also actually having those extenders has been so helpful with patient satisfaction and actually being able to to improve your reach.
And I would say one of the difficulties in saying, here, let me take it to the physician, the primary care physician, and let them kind of determine where this patient should belong. Once again, we really have had not much as far as a population health management strategy up until recently. And so there are a lot of new service lines that we're developing. And I feel like a lot of primary care physicians don't know where they should belong. And so I think it's Sharp-Reese-Steely that has your triage nurse. And that's kind of what I visualize in my head of saying, that's what I would like to do. I'd like to have an outpatient helpline. Like, this patient is complicated and I know I need help, and so I'm calling somebody. And you help me figure out what they need. You know, it's like on writing physical therapy, eval and treat. Yeah,
So concierge not for the patient so much as for you.
Yeah, exactly. Yeah. I feel like, and I go to all these meetings and I kind of know what's out there, but it changes all the time, you know, and who goes to which program or service and who meets this inclusion and exclusion criteria. And I have a good feel for it, but the person who's there day in, day out just seeing patients probably doesn't understand that.
So let me ask one more, and then I'll turn it over to the crowd. It's about IT, and you actually have taken different strategies, and you know, your strategy at Scottsdale is the same one we did it. And we had no two physicians chose the same EHR, and we actually were the organization that brought meaningful use into the community. You know, in terms of we were the local rep or whatever they called it. I can't remember what the names were, but we focused on the glue, the communication, the e-referral, the HIE, the staff messaging, you know, functions that brought everybody together. It started with a community-wide registry around chronic disease that captured pretty much the whole population for diabetes. That was around 2002. And you know, and it solved a lot of the physicians' problems about being able to follow their stuff, submitting quality data back in through that tool. You guys are a different strategy, which is trying to the 2-year plan. And you know, what are your thoughts hearing what Tiffany has to say, Aaron?
It's certainly a little more nimble, like you said. And part of it has been because we are directly related to the hospital, so we're trying to develop a communication strategy from our inpatient to outpatient, which is probably why we're moving that direction mainly, as well as other service lines, anything from our home health and hospice services to physical therapy lines to, anyway, so, but I could see, I've got jotted down here about things like Tiger Text, and for us right now, we're actually able to communicate internally within that system with fairly well within the 2 regions. We have two main electronic health records, and you can send internal communication pretty easily. I do look at, as we expand this out to other independent healthcare providers, certainly that could be something that could be beneficial or make it more palatable for them, because they feel somewhat excluded by not, because we are such a monopoly, as it were, there. I could see where they would feel
Nobody
excluded.
from the Federal Trade Commission.
I won't explain the lawsuit we just lost. So no.
Well, it sounds like you are integrating the care, so that should be at least a defense.
That's right.
when they drop the dime on you. Let me open it up to other people now, and other comments, thoughts about this.
2 quick questions. Well, they're not quick. You guys are tightly attached to the hospitals. Have they complained to you that you're making hospital beds empty with this? And number 2, has either of your outfits tried to get a Knox-Keene license?
Tried to get a what license?
A Knox-Keene.
You know, HMO license or sell insurance. Yeah. That's a California rule, but there are similar concepts under the
Okay, selling your own insurance then, yeah.
So yeah, I'm not sure under the second question. On the first question, as far as complaints about beds being empty, sometimes our finance guys a little bit, but once again, we're very blessed to have our CEOs realize the direction we're going and are willing to support us in that.
So our CFO was the hospital system CFO was on the steering committee for Scottsdale Health Partners and currently is serving as our board chair. So that's a really smart and important thing to do because they get it. I mean, they get what the mission is and that type of thing. Now, we haven't had people complaining that, you know, hospital beds aren't are empty and those types of things. But there have been some duality. I mean, we're really in a schizophrenic environment right now because there's still paid fee for service. There is service line development going on, and that's all about bringing in things to the hospital system, and we're about trying to keep it out of the hospital system. So they haven't complained, but there are certainly some schizophrenic messages that are going on right now. And then in Arizona, you don't need a Knox-Keene license. We have not looked at being an insurer, and right now, and the reasoning why is there's certainly potential there, but what gets me up every day is transforming the patient care, and that's our entire team. That's really what gets them up. And so I would much rather right now be focusing my creative energy on.
Well, I was saying because maybe you probably get better access to your own data then you would know which populations.
You would, but there's a ton of infrastructure that you have to build in order to be able to do that. And so, and that's it, when we're talking about building that kind of infrastructure, I have way less interest in doing that in the initial part than I do, than I may later.
And we actually broke off and created a whole separate network to do that contract negotiation. And once again, we actually contracted with a group out of Utah as a insurance provider to do similar to that, although they are not directly an insurer, but we're very closely aligned and partnered with the idea. But once again, it has been, even with that close alignment, has been difficult to get data from them. And it's starting to flow now, and I imagine now that the floodgates are open, hopefully that data will continue to come.
Maybe we could turn turn the question to the other people in the room. Anyone else using their Knox-Keene license in California or becoming a health plan?
No. Sutter is, yeah. You know, in Humboldt in the late 90s, we tried to become a community-based health plan and had a partner, you know, that was an insurance company that was going to provide some of the back office stuff. And after like 2 years of, you know, huge, you know, wasn't what got me up in the morning was doing that. But we wanted the data and control, local control, we abandoned. And it's more about how do we partner with the insurers that are out there.
Yeah.
Part of it was that the local employers viewed us as the fox guarding the hen house at that point.
Sorry, what you said, that brings up a point that I think has been hugely successful. We are really, all of us in this room are really on the brink of innovation. And so what we have also figured out in our IT partnerships is that we treat our IT as vendor partners, not just as vendor solutions. And so we've got great relationships with all of our IT vendors to help in the development of their tool sets to help support our programs. So our IOCP program right now, our documentation is paper. And the reason we did that was because there was no good system out there, and then we could figure out what we really wanted to do. And now we're using our HIE vendor to develop the system to help do the process that we already have. And we've done that with all of our different IT vendors because there's a lot of investment in this area right now, especially in the IT world. And I think it's been one of the things that has kept us so successful in being able to implement and roll out things that are really useful to our providers.